Welcome to the Didsbury Sidebar, everybody. Thank you for being here. Tonight we are lucky to have a good speaker with us tonight, Dr Anne Schlag from Drug Science, which is based in London. She's going to tell us about medical cannabis in UK and her project T21. That's right, isn't it?
Yes.
Brilliant. Thank you. Looking forward to it. Floor yours, Anne.
Thank you. Going to start sharing. I hope that works. Are you able to see the screen?
Yeah,
Yes.
We've got it.
Okay. Thank you for the introduction, Sarah. So yes, I'm head of research at Drug Science, and I'm going to speak about the long and winding road of medical cannabis here in the UK. That's my target is titled From Principle to Practice. So to give you an outline of what I'm going to speak about, I will briefly introduce Drug Science, our charity, which will lead us to discuss why we started the Drug Science Medical Cannabis Working Group, which obviously is a kind of topic today, and how we're developing the scientific evidence base on medical cannabis here in the UK. And I will provide just some examples of recent research. When I went through the past 3 years, what we've done, there is really too much research to speak about today. However, most of it is open access, and I'd be very happy to provide the slide with all the links for people who are interested in it. And also I'm available for any questions after the presentation and also generally. And obviously, main point of our research, which some of you hopefully will have heard of, is Project 2021, the UK's first real-world data registry. And I will present some very current findings from August. These are unpublished yet, so please don't share them widely. But yeah, so it should be very interesting, hopefully. And I conclude really with giving the wider context and the next steps and what we're hoping it's going to happen. And please feel free to ask questions during or after the presentation. Just to give you a bit of a background. Hello? Okay, just to give you a bit of a background about
the old-fashioned way. You'd have it on the lathe that way, wouldn't you?
If you don't mind using this.
Create that shape.
Excuse me, I think a few people need to mute, please.
It wouldn't be perfectly round.
Yeah, thank you. Thanks. Okay, so this is Drug Science, our charity. Please do check our webpage. And I would like to just highlight at the very beginning, we work with all kinds of drugs, from cigarettes and alcohol to obviously the currently considered illegal drugs such as heroin, cocaine, as well as cannabis and so on. And we pride ourselves on speaking the truth about drugs. Drug Science was founded in 2010 by Professor David Nutt, then chair of the ACMD, the Advisory Committee of the Misuse of Drugs here in the government, he was known as the drug czar. However, he was sacked from his position there for speaking the truth about drugs, for kind of saying that alcohol is actually more dangerous and more risky than taking MDMA. So that's not the kind of things that government and policymakers really wanted to hear. But of course, he and we at Drug Science stick to the scientific evidence base. So we are the leading scientific body on drugs in the UK. We remain independent and we work to provide clear evidence-based information without political or commercial interference. And our vision is to see a world where drug control is rational and evidence-based, where drug use is better informed and people who use drugs are understood, and where drugs are used to heal and not to harm. Very relevant, obviously, to cannabis and our discussion today. Our mission is to conduct and promote drug science so that public knowledge can be based on reason and evidence. And here you can see we have, obviously we do our research. We've got project T21. Obviously I can't see my screen just now, but you will be able to see on your screen that we have 3 different working groups: medical cannabis working group, as I mentioned, but also just launched last year the medical psychedelics working group, which is really going from strength to strength, and a slightly different supervised injection facilities group, working group, in order to provide safer injection facilities for drug users. So loads of interesting things. Under resources, we've got some excellent podcasts as well as the information about drugs. And I think we really cover a really broad range of drugs, a known one and the much lesser known one as well. So please do check it out and do sign up to our newsletter if you wish. So I'm going to provide a very quick intro to cannabis regulation. Should say that it goes beyond the kind of time of this presentation to look into the pharmacology of cannabis, the endocannabinoid system, and so on. We have loads of information pages on drug science on our webpage, which are freely available to look at and to share. So I'm just going to look at what's going on in the UK, what has happened the past 3 years, and where are we going to go from now, basically. So many of you will know that cannabis really is one of the world's oldest medicines, has been used, some people say, since millennia, with loads of evidence that it has been used in ancient China and India during these times. It is widely accepted that it was introduced into Western medicine in 1800 by the Irish physician Dr. Shaughnessy, and has been widely prescribed in the UK as well as in other Western countries for various issues related to pain, related to period pains, related to nausea. Apparently Queen Victoria used cannabis to help with period pains as well as the pain during childbirth. So has a long history. It has been used since the medicine it was widely available. However, in 1971, exactly 50 years ago today, cannabis became illegal under the Misuse of Drugs Act, also known as the MDA Act 1971. So that meant really that cannabis could not be prescribed as a medicine anymore, was considered to be of no medicinal value, which is really quite crazy if you consider the long history that it already had at that time. And of course, it also made it extremely difficult to conduct scientific research on the benefits as well as risks of cannabis. So it really hampered research on cannabis to a great extent. Obviously, the Misuse of Drugs Act, I should say, it goes further than just cannabis. The same as can be said for psychedelics, for example, but we're just focusing on cannabis for today.
Hi, baby.
Since
Are you on the screen?
Are you on the screen?
That's it.
Are you on the screen?
Are
you on the screen?
Since the early 2000s, cannabis has slowly been reinstated in the medicine, led really by various US counties and Canada, and in Europe progress has been slower. But in the UK, medical cannabis has been made legal or was rescheduled as a medicine since the 1st of November 2018. So pretty much nearly 3 years ago. And NICE, the National Institute for Care and Excellence, the government body developing the guidelines on various medications and their prescriptions and application, in 2019 recommended the use of a very limited, I should say, range of cannabis-based medicinal products, or CBMPS, for 3 main conditions. These are chemotherapy-induced nausea and vomiting, spasticity from multiple sclerosis, MS, or severe treatment-resistant epilepsy. So as you can see, it is a very limited range of conditions, and the range of cannabis-based products they recommended are also very much narrow. You will recall that cannabis obviously is not just one product. It comes in all different shapes and sizes, so to say, from the traditional, what many people, recreational users use, the kind of bud or weed or the flower, so to say, but then of course also the various oils and tinctures, sublingual can be used, and so on, as well as creams for the skin. So, but the UK, nevertheless, NICE in the UK, nevertheless limited the range of cannabis products available and that could be prescribed. So that, that's the first kind of issue, even though patients already had been using cannabis products for much broader range of conditions, which I will show in the next slide, I think. So a recent survey, representative YouGov survey, actually estimated that there are likely 1.5 million of medical cannabis in the UK, and who are treating a very broad variety of physiological as well as psychiatric, interestingly, conditions. So absolutely not reduced and limited to the range recommended by NICE. So that's the second issue. First issue, limited range of products available. Second issue, patients are using medical cannabis already, but for much broader range of conditions than recommended in the UK by NICE. So really, patient access, what's going on with that? That's why I will triple question marks behind it. So after nearly 3 years, only a handful of NHS prescriptions have been written to date. There are more private prescriptions, but these are still at a very high cost. So the cost of these has come down quite significantly the past 3 years related to economies of scale, but it is still, around 700-800 often per month. This is related to various issues. In the UK, import and growing regulations are still quite a challenge, but also the huge barriers to prescribing, which still remain after nearly 3 years. And these include, just to give the perceived lack of evidence, the perception that RCTs or randomized controlled trials are the only form of evidence. This is, for example, what NICE looked at. And when you look at RCTs only in relation to cannabis, some of the evidence is fairly weak. That cannot, because there haven't been as many randomized controlled trials conducted, mainly also for the reason that cannabis obviously was not considered a medicine for nearly 50 years. So, and there's little in clinical regulatory confidence in cannabis-based medicinal product. This really stands against patient testimonial. I mean, there are hundreds or even thousands of patients who really testify how much cannabis has helped for a broad variety of conditions. Coupled with this is also a lack of education by policymakers, by patients sometimes, although they are very keen and very quick in getting educated themselves, and importantly by healthcare professionals, including the prescribing doctors. So it's not really, most doctors are not taught about medical cannabis in medical school. At Drug Science, we've also developed modules which can be used in educational contexts, and there are various other groups such as the Medical Cannabis Clinician Society, who we collaborate with, who are actually offering registered modules for potential prescribers and so on. But lack of education is still quite prevalent, as is the remaining stigma in relation to medical cannabis. As many of you will know, kind of recreational use of cannabis, as most other drug use, is a highly stigmatized pastime, so to say. And recreational use, is often perceived to be associated with very negative images and so on for many people. So really, and unfortunately, we noticed that this particular stigma, also the risk of recreational cannabis, risk of addiction, for example, and so on, had automatically been transferred by doctors to the to medical cannabis, which is obviously not quite the case, because these medical and recreational cannabis, while the products might be similar, they are often very used in very different conditions for very different reasons and so on. So I think that's a very interesting point to have. Most of the patients we're dealing with do not actually want to get the kind of stoned or high feeling from medical cannabis. They want to take away their pain, their cluster headaches, to reduce their insomnia, to increase their appetite if they're going through cancer treatment, and loads of things like that. They have no interest in getting high from it, which obviously contrasts with many recreational users. So anyway, in light of these kind of issues, we launched a Drug Science Medical Cannabis Working Group in 2019. And just to give a brief oversight of who we are a consortium of medical cannabis experts, and these obviously include scientists, policymakers, quite a few patient representatives and industry partners. And we are funded in part by a consortium of these industry partners, but through an educational grant, which basically means they do not influence our outputs. And why we did it, I mean, that's kind of evident from what I've just spoken about, to improve the access of medical cannabis in the UK to patients in need. And how we're doing this by working together to develop and share scientific evidence on medical cannabis. As you really recall, the scientific evidence in many ways is lacking, and we really worked together and looked into how can we improve this. To give you just an outline, I'm very happy to share this slide. These are some of our selected publications, often obviously together and led with Professor David Nutt, where we really aim to move the evidence space further. One, just as an example, is here. This is a multi-criteria decision analysis comparing traditional drugs on the market to cannabis and various cannabis-based medical products. And we chose here the indication chronic neuropathic pain. We chose this, for example, because this is one of the conditions where NICE does not recommend prescription of medical cannabis for. However, it is, as you will see from the findings which I present in a minute, one of the conditions that patients actually use cannabis for most often. And, so it's such a discord between patient and what is offered here that it's really quite a controversial in a way. I will speak also here. This is our first article about T21 preliminary findings from our data evidence base. So I will be speaking a little bit about that. You can see here where we've looked at details in what I mentioned just now, cannabis-based medicines and cannabis dependence. So we really compared recreational cannabis use and users to medical users and critically reviewed the issues in order to really see, like, this is not the same use in many ways. And then we looked at the various current controversy, and one of the other issues which is very close to me as a mom, not just as a scientist really, and many of you will have heard about it, I assume, is medical cannabis and pediatric epilepsy here in the UK, and the really traumatic experience that a lot of the families have been going through the past 3 years, as well as longer, obviously. And I will speak about this if hopefully I have enough time, if I don't speak too long. So why do we want to move beyond randomized controlled trials? Obviously, randomized controlled trials are the gold standards in medicine, and many would argue rightly so, because accidents do happen, and we need to proceed with caution. It's absolutely clear. But our view is that the perception of RCTs as the gold standard in relation to cannabis, medical cannabis, should really be widened. Reasons for this are manifold. I mean, obviously, cannabis is a very old medicine. It is not a new medical product. There hasn't been a death from medical cannabis, and it does not have this. And we have been using it, not just we, but for millennia. But RCTs, most importantly, really are not the best way to assess the efficacy of medical cannabis, because, as I said, cannabis is not one product, but about 140 different cannabinoids so within the product. So the variety of compounds makes it very hard to assess the evidence. One would need to test all different cannabinoids and in different ratios in order to find out really what is the most effective. So if the sole focus remains on RCTs, results will take years to develop. Yet patients really could benefit from the medicine now. So really our aim is here to include other evidence to improve patient access, audits of patient already using the medicine, multi-criteria decision analysis, observational trials such as Project T21. So So just to give you an idea this is just from a paper which we published just this year on current controversies in medical cannabis. And really the controversies, the issue, which I've just highlighted here, is you can see the strength of the evidence, which we fully agree is fairly low if one looks at systematic reviews and randomized controlled trials and so on. However, for this particular analysis, we also took into account the relative number of patients here from the low to the high number of patients. You can see, for example, chronic pain, unfortunately, has a very high number of patients, as do anxiety, depression, sleep disturbances, and so on. High number of patients and people suffering from it, but the strength of the evidence is not particularly strong. So the controversy was really, what are we going to do with all of that? Whether here, these are the kind of the high strengths of evidence, low numbers of patients, thankfully, intractable epilepsy, multiple sclerosis, cancer-related nausea. These are the areas that NICE does recommend cannabis for. And here in the left-hand corner, low strengths of evidence and thankfully also low relative number of patients with strongly developing evidence, I should say, a very broad range of other issues which haven't been researched sufficiently yet, but which I think, where cannabis has a strong potential to be used in the future. So looking at these current controversies, it was just really evident to us that we need to improve our knowledge about medical cannabis, because there is a widening range of human clinical applications. It's absolutely, it's evident. There's some use now in terms of COVID, long COVID, and so on as well. So it seems to be always developing. And some of the conditions for which medical cannabis are used are well established by now, as I mentioned, while others remain really controversial and just not sufficiently explored, at least when one looks at randomized controlled trials. And the strongest empirical data, as I said, supports the use of medical cannabis with conditions for relatively small patient numbers. But the conditions with the highest patient numbers often still have debatable clinical evidence, but good real-world evidence, which I'm going to speak about now, which we're going to look at. So really this discourse between real-world evidence and the strength of evidence from RCTs really highlights the need for further research on one hand, but also highlights the need to actually listen to patients a bit more and take their views and their experiences into account. So this is what we have done. I'm going to speak briefly about epilepsy, which is an issue. I don't know how many of you have heard of the issues related to pediatric epilepsy here in the UK. A lot of the parents have been very vocal, have been on the BBC, and really have been sharing their plight, their painful plight, with the public, basically. What we have done, which has been published in peer-reviewed journals now, and we are awaiting a third paper actually, we looked at the pharmacological and physiological effects of medical cannabis in pediatric epilepsy, and really how the reduction in seizures, obviously, but also including the financial cost of treatment, current and past anti-epileptic drug use, and the particular diagnosis, and so on. And this was then followed by our part 2, narrative and in-depth interviews with the parents and the carers of these children. And really to look at the benefits and risks of medical cannabis, the prescribing history, the side effects, and the kind of hopes, concerns, and issues that these families are experiencing. To really to put a human face to it, because we feel, just apart from obviously the medical issues, the reduction of seizures, it is such a, it potentially can change their lives in such a way that is not adequately covered just by a quantitative analysis. So that's why we added the qualitative side as well. Just to give you an idea for those who haven't seen it, and again, this is freely available obviously on our webpage as well as our journal, Drug Science Policy and Law. These are here the patients. We had the patient numbers, and these are the number of monthly seizures. As you can see, absolutely horrendous, going up to 10,000 and so on. You can see these are extremely ill children, living with disability. These are not people who have only, in inverted commas, an epileptic fit a week or something. These are extremely, extremely poorly ones. And all of them had amazing reductions in seizures. As you can see, patient 8 and 9 had an incredible reduction in the monthly seizures. And indeed, there are some children who have been seizure-free for a year now. So the average reduction in seizures, as you can see, is halved, and obviously more than halved, and was obviously highly significant. So we're using the Wilcoxon sign rank test. So 80% mean reduction in seizure frequency across the cohort. So absolutely incredible. Okay, having said that, it's not that straightforward. You would think that prescribers then would jump at the opportunity to prescribe the severely ill children medical cannabis products, or the medical cannabis products they really need, and that is shown to benefit them incredibly. But it's not really, wasn't that simple, still isn't that simple. I should add, this is another thing we have published, that it was not just the reduction of seizures, but also when we looked at quality of life of the pediatric patient and their families. The quality of life includes not only far less seizures, but also better sleep, better eating and digestion, more awareness and alertness, wide-ranging cognitive and physical improvements, reduction in other medicines with stronger side effects, and overall improvements in happiness and well-being. And one mom phrased it that way. Within 3 weeks of taking Bedrolite, the medical cannabis products, she started to improve massively. Basically, her life was transformed. So she doesn't use a wheelchair. It wasn't a cure, and it isn't a cure, but she was able to go out. We were managing to drop one of the other drugs that she was on, and her IQ came up massively. So again, highlighting also just the overall benefits in terms of quality of life, and also quality of life of the parents, because then they can actually do something with their children rather than just being fearful and absolutely scared that they're having suffering another seizure. However, one of the issues, as you can see, this shows the monthly cost of the cannabis-based medical products for these families. And as you can see, these are extremely high, sometimes over £2,000. Yeah, it's absolutely terrible that it should cost that much, because as you will know, obviously, epilepsy is a chronic condition. It is not a one-off payment. This is probably the payment for life. Yeah, so absolutely dreadful, because families had to sell their house had to move country, move to the Netherlands in order to get the product in a slightly more sustainable fashion, and so on, disrupt the life completely. And really, that should not be the case. I should say that the monthly cost of this product has reduced quite a little bit since we have done this study, but it is still in the realm of 900 or 1,000 a month, which is, is quite a lot for most people. So what are we doing? So in Project T21, which we started, which was launched last year in order to combat some of these issues and to make medical cannabis more accessible to patients, and not just the epilepsy patients, but just a much wider range of patients. So we were UK's first national medical cannabis real-world registry collating data. We have a stretch target of up to 20,000 patients to access cannabis-based medical products through 21, which obviously, as I say, it's a stretch, but who knows what might happen. And the cost of the medication are capped at £150 a month, which is kind of the best available in the UK at this point. We're still hoping to get it lower as well. And T21 consists of a multi-stakeholder partnership with academia, industry, clinicians, and obviously the patients. Patients had a huge impact in the design of the product. And the aim is to collect the largest body of evidence for the effectiveness and tolerability of medical cannabis. And just be assured, we publish the data regardless of whether it is favorable or not, obviously. And you can see our first publication was published earlier this year as well. The indications we're covering are pretty wide-ranging. Chronic pain, obviously, analyzed with the brief pain inventory short form, anxiety disorder, using the generalized anxiety disorder 7-item scale, PTSD, post-traumatic stress disorder, where we're using the checklist for DSM-5, Tourette syndrome, using Tourette syndrome in the Yale Global Tic Severity Scale, multiple sclerosis, the Extended Disability Status Scale, and substance use disorder, also the severity of dependence scale. Epilepsy, I should say that unfortunately so far we only have adult epilepsy, mainly for the reason that we haven't found a pediatric neurologist willing to prescribe. So if there are any pediatric neurologists out there, please get in touch with me after. And for the epilepsy, we're using patient-weighted quality of life in epilepsy plus the number of seizures. And measured assessed on all patients includes sleep quality, quality of life assessed by the EQ5D, and mood by the PHQ-9. So demographics, diagnosis, as well as comorbid conditions, medication, and previous failed treatments, cannabis products and dosing, adverse events, and primary outcome measures are assessed for each of them, and they are taken by the doctor, by the prescriber at the very beginning of the prescribing, using very established Canadian software, CB2 software, and then checked at 3 monthly intervals. The preliminary results, this is from last month, 31st of August, what we have. So we have over 1,660 patients with clinical appointments, and 1,479 individual patients have now contributed their data to T21. The majority were male, and the average age was 38.9 years. As you can see, very much varied age range, literally from 18 to 84. So it's not just young people or anything, or not very old people either. So kind of middle-aged, I would say. Primary conditions, similar to other databases which we've looked at, the two most common primary conditions for which people seek treatment are pain. Moreover, the half of people are asking for medical cannabis prescription to combat their pain, followed by anxiety disorders, which I think is a very interesting topic as well. So together, these two conditions already include 87.2% of the whole sample. And here you can see this is then followed by post-traumatic stress disorder, PTSD, multiple sclerosis, epilepsy, and substance use disorder and Tourette's. And I should say this is quite similar to what other international databases, such as by Health Canada in the US and in Germany, have also been finding. I think very interesting, multimorbidity was common, not unexpected, obviously. So participants were asked whether they had been diagnosed with any other physical or mental health problems. Most common were stress, nearly a third, insomnia, also nearly a third, depression, nearly half of them, back and neck problems, and anxiety. So you can see the number of secondary conditions. Very few actually had no other condition apart from the prescribed primary condition. Several had 1, 2 or 3 was common, 4 or 5, 6 or 9, and some even had more than 10 secondary conditions. So that really, these are pretty ill patients. They're not coming just because they have a tiny issue. Most of them had quite a few issues, serious issues. And I think interesting to note, really, since we spoke about randomized controlled trials earlier on, these participants would have automatically been excluded from randomized controlled trials, because as you will know, RCTs are looking for the efficacy of a product in a particular condition. Not maybe 2 or so, but not these type of numbers of condition. It would just be too difficult to analyze. So really, I think this highlights very much the value of having patient-reported outcomes, of really letting the patient talk, because in many ways they do know best what the issues are. And I think that's one of the most interesting findings to date as well, on quality of life, which again, as you could see, also came out in terms of the quality of life of the families with the epileptic children. So the self-reported quality of life was assessed using the EQ5D, a very well validated and widely used measure. So, very traditional in science. So normative data for the UK household population are available and have been shown by Devlin et al. In 2018. So we used these scales. These are a 1 to 100 measure of the current health, where 100 is the best imaginable and 0 obviously no health at all. And you can see here the mean for our project is 48.6, while the mean from UK households is actually 85.7. So a huge difference in these two in terms of quality of life. You know, we found that is very important data. In a similar way, we looked at levels of depression, which are also strongly severe, prevalent in our sample so far. So all participants completed the PHQ-9, again, a very well-validated depression index, which assesses mood as well as depression. So this really illustrates the levels of depression in our sample. And again, we did a comparison to a German normative sample where high depression scores were 15 plus, and it was reported by only 1.3% of the normative sample, of the general population sample. But here, as you can see, our high depression rates are kind of reported by half of our sample, nearly half of our sample. So huge difference, and certainly again indicating that these are ill people, you know, so there's lots of issues. Again, although we measured looking at sleep, although this was not one of the primary conditions, qualifying conditions for T21, it is a transdiagnostic component of many of the disorders being studied, such as pain, depression, and pain, obviously, you know, that you can't sleep very well anymore. And many of these patient groups experience substantial difficulties of sleep, which in turn obviously impacts their quality of life, ability of work, to share, and relationships to quite a large extent. Yeah, you know, 63.3% reported that their sleep patterns interfered with their daily activities, much or very much. Others had severe or very severe problems falling asleep, staying asleep, or severe and very severe problems waking up too early, none of which make for a good and productive quality of life, unfortunately. So again, I think we're coming back to quality of life, and you know, anything that can be done in these situations, I think we should really keep a very much open mind to it. Looking at our 3 months follow-up data, again, as I said, this is longitudinal data. We're hoping to follow up over several years. We had the 3 months follow-up data for 466 individuals. And again, the self-reported health, the EQ5D, scale showed improvements from a mean rating of 47.2 to 61.6. This is obviously highly statistically significant, you know, improved by half that kind of self-reported effects. And this really, in light of any other changes that we're not measuring, it absolutely clearly shows that a large effect of prescribed cannabis on improving the health for this patient group is prevalent and can be shown. So I think what is important and what I would like to highlight is really, speaking about stigma earlier thing, we can use, you know, we can dispel the myth to combat the stigma already, I think. Our patient population comprises a huge age range from 18 to 80 years old. Their consistently high rates of comorbidity and very low quality of life demonstrate just how unwell many of them are. So the stereotypes of medicinal cannabis users as being 20-something and healthy recreational users looking for a legal source could not really be further from the truth. You know, these are ill people who are being helped by cannabis. So T21, our ongoing research and future developments about patient-reported outcomes will continue to be assessed at 3 monthly intervals. We will continue the project as long as we can, at least in the next 2 years. We are looking at the moment at condition-specific analysis, such as focusing specific on pain and the different types of pain that people experience, because of course different you know, products and different rates are good for different, maybe good for different types of pain. We'll of course also look at the gender differences. This data, as I said, is longitudinal, which I think is very important, longitudinal collected and analysis, and to look at the benefits as well as risks. Maybe in the future we will, you know, we will have to focus on some other issues as well. And one of our aims is also, and we are actually already in contact with Canadians and American databases or scientists there is really a development and collaboration with international comparisons. So we can get, hopefully a few thousand of patients, but many more exist already and have been looked at in Canada and America, as well as Germany. The French are starting a collection of databases now too, and so on. Unfortunately, the challenges to prescribing still remain. Doctors often lack knowledge and training in cannabis medicine, so education is key. And I mentioned before what we are offering and what we continue to provide for that. We're working closely together with a broad variety of absolutely excellent doctors, I should say. So, people are changing their mind, have changed their mind. And we always think the education to doctors is best that it comes from the prescribers and from physicians and their first-hand experience themselves. But clearly more work remains to be done to improve sustainable access to medical cannabis for patients. So conclusions, our research, including T21, as well as the auditor work on pediatric epilepsy, clearly highlights the importance of real-world evidence. And current real-world evidence continues to gather data and evidence for many conditions. And such results, we feel, should be included in regulatory decisions. Especially in the absence of RCTs for many of these conditions, we really should listen to the patients to a greater extent. Real-world evidence is building up to a kind of quite consistent pattern of evidence. As I mentioned, the results from our database are very much similar to results of Canadian and US databases. So really there is something there. It's not just us analyzing the data and particular products and so on. And we hopefully we can use this to support the use and prescription of medical cannabis to treat pain and various psychiatric disorders in the future as well. Real-world evidence and patient-reported outcomes also highlight areas for further exploration, where rigorous clinical trials may be required. And this is, of course, especially the case for psychiatric disorders, where we do know from certain recreational issues and from high-risk behavioral cannabis use that there are associated risks as well. So really, we do need to look into things in more detail in many ways. But including the qualitative evidence, which in many ways people would say was what we are doing in contrast to RCTs, does certainly not diminish the value of RCTs. It really can add to it, it can complement it, it can shed a different perspective on it and so on. And we have more work currently in development, really also because obviously one of the kind of issues in relation to NICE and one of their guiding principle is the cost effectiveness of a drug, and cannabis in many ways was not found to be cost effective. However, we will be conducting a full health economics analysis to really compare medical cannabis to other products on the market, but also in relation to kind of health savings for the NHS, for the patients in terms of quality of life, can patients return to work and so on. So taking a much broader perspective, which we think is also very relevant and very interesting, hopefully. And we are fairly confident that this will continue to show a positive picture. I should say that obviously I did not do this work by myself. We have the most amazing T21 scientific oversight board led by Professors Michael Linsky, David Nutt, Mike Barnes and Val Curran, as well as prescribers and so on of our clinics. So thank you very much for listening. This is our webpage for drug science. If you want to find out more detail about T21, specifically, please do go to the webpage and look at Project T21 specifically. And any questions, please, you can feel free to email me as well or follow me on Twitter. So thank you very much. I'm going to stop sharing now and we'll be available for questions.
Thank you.